This is the gross image, a very classical image of Alzheimer's disease, which is showing cortical atrophy. Now, what you see over here, okay, this is your widened sulci. And what you see over here, this is your narrowed gyrus, okay. So, this is basically showing a widened sulcus with a narrow gyri, which is responsible for cortical atrophy. And because of this cortical atrophy, that will be compensated by ventricular enlargement, and a condition called as hydrocephalus ex vacuo will develop. This is a very important stain that is called as the Belchovsky silver stain. Okay, it is showing the classical senile or neurotic plaque over here. So if you look at this particular diagram over here, okay, this is the silver stain which is very clearly showing this process. So what I want to show you over here, if you see at the center, this part, as you can appreciate, this is a central part containing the A beta peptide, okay, and on the outside periphery, the presence of dystrophic neurites is there, okay, dystrophic neurites are there. Okay, so this is very commonly seen in case of Alzheimer's disease. This is the Belchovsky silver stain, which is demonstrating the senile or neuritic plaque. So this is the initial starting protein. As I already told you, this is your amyloid precursor protein. So this protein that we can appreciate over here, this is the amyloid precursor protein. Now remember, this protein, as we can appreciate, okay, there are different parts at where the different enzymes are acting. So at the bottom, if you see, the gamma secretase act. Then in the middle of the alpha beta peptide, your alpha secretase is acting. That is, in the middle of the APP precursor protein, your alpha secretase is acting. And at the top of the amyloid precursor protein, the beta secretase is acting. Now, depending on which enzyme is acting on this amyloid precursor protein, it will be decided whether the person will have Alzheimer's disease or no. Okay, so let us now begin. So the first pathway, as I told you, which is the non-amyloidogenic pathway, okay, over here there is activity of alpha secretase and gamma secretase. So this is basically your amyloid precursor protein, as we can appreciate over here. Now what happens, because of the action by the alpha secretase enzyme, which is acting in the middle of the amyloid precursor protein, okay, and that is followed by the activity of the gamma secretase. So alpha cleavage site is here and gamma cleavage site is here. And as a result of this, you are getting a peptide fragment, okay, you are getting this fragment. So the end fragment that you get over here is this. This is the end fragment that you get in the non-amyloidogenic pathway. And this fragment is soluble. It doesn't tend to aggregate. So it is not causing Alzheimer's disease. Now let us look at the second pathway, which is the amyloidogenic pathway. So the amyloidogenic pathway is seeing activity of two enzymes, most importantly, that is the beta secretase followed by gamma secretase. Now what is happening, the beta secretase is acting more superficially towards the N-terminal end, as we can appreciate over here, okay, and the gamma secretase is acting where it was acting, okay, towards the it was acting intramembranously, okay, they act intramembranously. So it was acting in a similar manner as it was acting in the previous pathway. But what is happening, that this particular type of cleavage, where it is involving the beta secretase along with the gamma secretase activity, okay, this led to the formation of a peptide, that is A beta monomer, and more specifically it was A beta 42 monomer, okay, and this A beta 42 monomer, this wasn't soluble. Unlike this was not soluble. So initially it was formed as a monomer, which ultimately formed oligomers, okay, they joined together to form oligomers, okay, and this alpha beta oligomer is actually going to aggregate to form alpha beta aggregate like this. So it is going to form one aggregate, and this aggregate is again going to form amyloid fibrils, which can be seen by microscopy. By microscopy, in this form you can appreciate them under the microscope. And this amyloid fibrils actually is responsible for the formation of plaques and tangles, which are the pathological hallmark of Alzheimer's disease. Not only this, the alpha beta oligomer that is formed, okay, they can cause synaptic dysfunction, they can cause cell death, they can also, via other pathways of cell injury, they can cause neuronal damage. So this is the biggest disadvantage of this alpha beta oligomer. Myself, Dr. JIBRAN presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to do another very important high yield topic. Today we are going to discuss Alzheimer's disease. Now, it is the most common cause of dementia in elderly with increasing incidence with age. It is one of the most important neurodegenerative disorder affecting mainly the cerebral cortex. It usually begins after 50 years of age, and most cases they are sporadic. Only 5 to 10% cases are familial. Now coming to the pathogenesis of Alzheimer's disease, that how the neurodegeneration occurs in case of Alzheimer's disease, let us try and understand that. The fundamental abnormality in Alzheimer's disease is the accumulation of two important proteins. One is A beta protein, another is your tau protein. And this accumulation takes place in specific regions of the brain because of increased production and defective removal of these proteins. Now, two pathological hallmarks of Alzheimer's disease is the presence of number one, amyloid plaques, and number two, the presence of neurofibrillary tangles. So, what is amyloid plaque? Amyloid plaque is nothing but the deposits of aggregated A beta peptide in the neuropil. Okay. Whereas what is the neurofibrillary tangle? These are aggregates of tau protein which develops intracellularly and then persist extracellularly after neuronal death. So there are two very important pathological hallmarks of Alzheimer's disease. I repeat once again. Number one is the presence of amyloid plaques, which are nothing but the deposits of aggregated A beta peptide in the neuropil, whereas the neurofibrillary tangle, basically these are aggregates of tau which develops intracellularly. So initially this aggregation of protein is present inside the neuronal cytoplasm, but after the death of the neuron they are present extracellularly. Remember, amyloid plaques are again, these are extracellular accumulation, okay, extracellular in nature. Now remember that both the plaques and the neurofibrillary tangles, they contribute to neuronal dysfunction in the Alzheimer's disease. Now very important thing is that A beta generation is the critical initiator of the development of Alzheimer's disease. So the basic pathogenesis starts with the accumulation and generation of A beta, and after that there is the role of tau protein. So initially the disease process is starting or developing with the accumulation and aggregation of A beta peptide. So let us see individually what are the roles of individual proteins in the pathogenesis of Alzheimer's disease. So number one, we are going to see the role of A beta peptide. Now before I start with that, let us first have a basic idea over here. That is the very important idea that we should have, is that APP, if you see, APP is a amyloid precursor protein. So APP stands for amyloid precursor protein. Okay. So normally this amyloid precursor protein, it is a transmembrane protein that can be processed by two pathways. Okay. It is a transmembrane protein that can be processed by two pathways. The first pathway involves cleavage by two enzymes. One is the alpha secretase and another one is gamma secretase. Whereas the second pathway involves cleavage by another two enzymes, that is the beta secretase along with gamma secretase. In both these pathways, the gamma secretase activity remains constant. So this cleavage by alpha plus gamma secretase, okay, this leads to the production of harmless soluble peptide. This is called as non-amyloidogenic pathway. Whereas the other pathway, which involves the beta secretase enzyme along with gamma secretase, leads to the formation of pathogenic A beta molecule, which is responsible for the pathogenesis of Alzheimer's disease, and this pathway is called as amyloidogenic pathway. So remember, the initial protein, okay, from where we begin is amyloid precursor protein, and there are two pathways by which it is processed. If it is processed by this first pathway, that is the non-amyloidogenic pathway including alpha secretase and gamma secretase, then a harmless soluble peptide is formed and there is no Alzheimer's disease. Whereas if they are processed by beta secretase and gamma secretase, then pathogenic A beta peptide is produced. Okay. So let us now start the pathogenesis in detail. So this is the initial starting protein. As I already told you, this is your amyloid precursor protein. So this protein that we can appreciate over here, this is the amyloid precursor protein. Now remember, this protein, as we can appreciate, okay, there are different parts at where the different enzymes are acting. So at the bottom, if you see, the gamma secretase act. Then in the middle of the alpha beta peptide, your alpha secretase is acting. That is, in the middle of the APP precursor protein, your alpha secretase is acting. And at the top of the amyloid precursor protein, the beta secretase is acting. Now, depending on which enzyme is acting on this amyloid precursor protein, it will be decided whether the person will have Alzheimer's disease or no. Okay, so let us now begin. So the first pathway, as I told you, which is the non-amyloidogenic pathway. Okay, over here there is activity of alpha secretase and gamma secretase. So this is basically your amyloid precursor protein, as we can appreciate over here. Now what happens because of the action by the alpha secretase enzyme, which is acting in the middle of the amyloid precursor protein, okay, and that is followed by the activity of the gamma secretase. So alpha cleavage site is here and gamma cleavage site is here, and as a result of this you are getting a peptide fragment, okay, you are getting this fragment. So the end fragment that you get over here is this is the end fragment that you get in the non-amyloidogenic pathway, and this fragment is soluble, it doesn't tend to aggregate, so it is not causing Alzheimer's disease. Now let us look at the second pathway, which is the amyloidogenic pathway. So the amyloidogenic pathway is seeing activity of two enzymes, most importantly that is the beta secretase followed by gamma secretase. Now what is happening, the beta secretase is acting more superficially towards the N-terminal end, as we can appreciate over here, okay, and the gamma secretase is acting where it was acting, okay, towards the it was acting intramembranously, okay, they act intramembranously. So it was acting in a similar manner as it was acting in the previous pathway. But what is happening, that this particular type of cleavage where it is involving the beta secretase along with the gamma secretase activity, okay, this led to the formation of a peptide that is A beta monomer, and more specifically it was A beta 42 monomer, okay, and this A beta 42 monomer, this wasn't soluble. Unlike this was not soluble. So initially it was formed as a monomer which ultimately formed oligomers, okay, they joined together to form oligomers, okay, and this alpha beta oligomer is actually going to aggregate to form alpha beta aggregate like this. So it is going to form one aggregate, and this aggregate is again going to form amyloid fibrils, which can be seen by microscopy. By microscopy, in this form you can appreciate them under the microscope, and this amyloid fibrils actually is responsible for the formation of plaques and tangles, which are the pathological hallmark of Alzheimer's disease. Not only this, the alpha beta oligomer that is formed, okay, they can cause synaptic dysfunction, they can cause cell death, they can also, via other pathways of cell injury, they can cause neuronal damage. So this is the biggest disadvantage of this alpha beta oligomer or the alpha beta aggregates that is formed. It can lead to synaptic dysfunction, cell death, and via other pathways they can cause neuronal damage. Not only that, this alpha beta, this monomer formation is actually the initial step in the pathogenesis of Alzheimer's disease. Now once this alpha beta is formed, it is also causing kinase activation. It is causing kinase activation, and this kinase activation is now triggering tau phosphorylation, ultimately causing what is called as tau aggregation, okay, and this tau aggregation is again leading to neuronal damage in the end, okay. How? By causing microtubule disassembly. They are very important components of the microtubule. When there is tau hyperphosphorylation, it leads to microtubule disassembly. So this is the entire pathogenesis of Alzheimer's disease in details, okay. So this is very, very important for you people to understand, okay. Now let us see the familial forms of Alzheimer's disease that is there. So let us try and understand the pathogenesis of the familial forms of Alzheimer's disease. Now familial form of Alzheimer's disease, it supports the central role of A beta generation as a critical step in the initiation of Alzheimer's disease pathology. So the starting point is the formation of A beta peptide, its aggregation to form tangles and plaques. So this is where the process starts. Now gene encoding the APP, okay, gene encoding the amyloid precursor protein, it is present in the chromosome number 21, okay. This is the Down syndrome region. This is the region where abnormalities occur in the Down syndrome patient. Now patient with this syndrome, they experience early onset dementia. So patients with this syndrome, that is patients who are with Down syndrome, they present with early onset dementia, okay. Now localized chromosome number 21 duplication spanning the AP or amyloid precursor protein locus is seen in some patients with familial Alzheimer's disease. Now point mutation of this amyloid precursor protein gene is also causative of the familial Alzheimer's disease, and gain of function mutation occurs in two genes. Let us first see the normal function of these genes. The PSEN present in the chromosome 14 and the PSEN2 which is present in chromosome number 1. So these are encoding two proteins, one is presenilin 1 and presenilin 2. Now both of these normally they cause gamma secretase activity normally. So if there is a gain of function mutation in the genes encoding presenilin 1 and 2, that is PSEN 1 and PSEN 2 respectively, they are going to increase the activity of gamma secretase, and that is causing increased production of alpha beta peptide, mainly alpha beta 42, which is responsible for the pathogenesis of Alzheimer's disease. So let us just see the familial form of autosomal Alzheimer's disease once again. So very importantly, the familial forms of Alzheimer's disease, they are basically occurring. For example, patients who are patients of Down syndrome, usually they present with early onset dementia, and the genes which are encoding the APP, that is the amyloid precursor protein, is present in the same place where abnormalities of chromosome 21 in the Down syndrome patient is taking place. So there is some association or some mutation or some alteration is taking place in the APP gene, which is encoding the amyloid precursor protein, such that these people are suffering from Alzheimer's disease. Secondly, sometimes localized chromosome 21 duplications, which is involving again this amyloid precursor protein locus, that is the APP locus, is again seen in familial form of Alzheimer's disease. And point mutations in APP gene also contributes towards familial Alzheimer's disease. So there is some relation between Down syndrome or any kind of localized chromosome 21 duplication or some point mutation in the AP gene. Apart from that, gain of function mutation in the PSEN1 and 2 gene again increases the gamma secretase activity and they increase A beta. So again, they might be responsible for familial forms of Alzheimer's disease as well. Okay. Now we have seen the role of A beta protein, A beta peptide. Now we are going to understand the role of tau. Now very importantly, we have to understand that the Alzheimer's disease, the beginning point of Alzheimer's disease is the formation of A beta 42 peptide. Okay, we have already seen. And this is the one which in the later stages will cause hyperphosphorylation of the tau protein. So what is tau? Normally tau is a microtubule associated protein which is present in the axons. Okay, the neurons, they are having a cell body and they are having a axon. Okay, so this is the soma along with the dendritic process, and this is the axon. Okay, so with the development of neurofibrillary tangles in Alzheimer's disease, it shifts to a somatic dendritic distribution. Okay, that means normally the tau is situated somewhat over here. Now with the development of Alzheimer's disease, the tau protein is going to relocate towards the cell body, towards somatic dendritic distribution, that is towards the soma and dendritic process. They will become hypophosphorylated, okay, and loses the ability, okay, to bind to microtubules. So the tau protein, they will lose its ability to bind to the microtubules. Now the mechanism by which the tau protein injures the neuron is not very well understood, but two possible pathways have been hypothesized. So this might be asked, it might come as an important MCQ. One is your aggregation of tau, which elicits a stress response, okay, or loss of tau destabilizes the microtubule. So either of these two mechanisms are responsible for the neuronal injury which is caused by the tau protein. Okay, so we have seen basically in the pathogenesis, we have read in details what is the role of A beta peptide. Then we have seen the familial form of Alzheimer's disease. Then we have read about the role of tau protein. What are other genetic risk factors? Let us try and understand. Now remember, now there is a particular locus which is present in the chromosome 19, which is encoding for apolipoprotein E. Okay, now apolipoprotein E, structurally they influence, they have a structural influence on development of Alzheimer's disease. How? Let us try and understand. So basically this particular chromosome, okay, 19, the locus which is encoding this apolipoprotein E, it is having three alleles. One is E2, E3 and E4 allele. So there are three important alleles which are present in the chromosome 19 at a locus which is encoding apolipoprotein E. Now out of these three alleles, one allele, that is the E4 allele, increases the risk of development of Alzheimer's disease. And this ApoE isoform promotes A beta generation as well as deposition. Plus, now this is one form, this is one way of causing Alzheimer's disease. Okay, another pathway by which this ApoE4, okay, is causing Alzheimer's disease, that is A beta independent. This is only tau mediated neurodegeneration. So without the help of your A beta peptide, they are causing tau mediated neurodegeneration as well. So overall, this locus conveys about 1/4 risk for development of late onset Alzheimer's disease. Okay, so this is a very important, another very important risk factor, that is the apolipoprotein E4. Okay, E4 is increasing the risk of acquiring Alzheimer's disease. Now, what is the role of inflammation in Alzheimer's disease? A beta elicits inflammatory response. A beta is eliciting inflammatory response from the nearby cells or from the supporting cells of the central nervous system, which are the microglial cells and the astrocytes. Now, what are these? Microglial cells are nothing but they are the macrophages. So they help in clearing the A beta deposits. And these cells, because they are inflammatory cells as well, they are releasing certain mediators which is causing oxidative damage to the neurons. They are altering the tau phosphorylation and they cause aberrant pruning of the synapses. Okay, so this is the role of inflammation in the causation of Alzheimer's disease. What is the basis for cognitive impairment in Alzheimer's disease? Okay, the increased formation of plaques. Okay, the increased formation of plaques and tangles, they are highly associated with cognitive dysfunction in Alzheimer's disease. The number of neurofibrillary tangles, they correlate better with the degree of dementia than does neuritic plaque. This is a very important MCQ. So, is it the tangles or is it the plaques that correlate better with the degree of dementia? So, the answer will be the neurofibrillary tangles are correlating better with the degree of dementia as compared to the neuronal plaques. Okay. Now, biomarkers correlating, now remember, biomarkers correlating with the degree of dementia. What are certain biomarkers which correlate with the degree of dementia? Number one, loss of choline acetyltransferase activity, loss of synaptophysin immunoreactivity and amyloid burden. So these are the three important biomarkers which are correlating with the degree of dementia. Okay. So let us see. So these are correlating with the degree of dementia. Now let us see what are the biomarkers which is done for early diagnosis and prevention of Alzheimer's disease. We have seen the biomarkers for assessing the degree of dementia. But what are the biomarkers for early diagnosis and prevention? So A beta deposition in the brain can be demonstrated by imaging methods by using 18 fluorescent labeled amyloid binding compound. Number one. Number two, by presence of increased phosphorylated tau and decreased A beta in the CSF. So in the CSF, if we see more amount of phosphorylated tau and decreased A beta, then that is suggestive as a biomarker for early diagnosis of Alzheimer's disease. So it is suggestive of development of early Alzheimer's disease. So we have completed very importantly the pathogenesis of Alzheimer's disease, wherein we have read in details about the role of A beta peptide. Then we have seen the familial form of Alzheimer's disease, the role of tau protein, other genetic factors, that is apolipoprotein E4, then the role of inflammation, basis for cognitive impairment, and the biomarkers that we have already seen in details. Now, this is a very, very important question. Pathogenesis of Alzheimer's disease carries around 10 to 15 marks. So, you have to discuss in details as I have discussed right now. Now, coming to the morphology of Alzheimer's disease. Now, most common thing that you are going to observe over here, if you see, is the cortical atrophy. That is, and how will you appreciate? The gyrus will become narrow, whereas the sulcus will become widened. Okay, and this is taking place in the frontal, temporal, and parietal lobe. Now, due to significant atrophy, because there is significant atrophy, so brain compensates by ventricular enlargement. So there is a compensatory ventricular enlargement, and this is called as hydrocephalus ex vacuo. Okay, it is called as hydrocephalus ex vacuo. Now, the earliest sites to be involved over here, if you see, it is the medial temporal lobe structures. So, what are the medial temporal lobe structures which are involved? It includes the hippocampus, entorhinal cortex, and amygdala. So, these are the important structures which are involved. Okay. This is the gross image, a very classical image of Alzheimer's disease, which is showing cortical atrophy. Now, what you see over here, okay, this is your widened sulci, and what you see over here, this is your narrowed gyrus. Okay, so this is basically showing a widened sulcus with a narrow gyri, which is responsible for cortical atrophy, and because of this cortical atrophy, that will be compensated by ventricular enlargement, and a condition called as hydrocephalus ex vacuo will develop. Coming to the microscopic features of Alzheimer's disease, the first very important feature is the development of neuritic plaques. Okay, the development of neuritic plaques. Now, what are neuritic plaques? These are focal spherical collections of dilated tortuous axonal or dendritic process. Okay, and such dilated tortuous spherical collection of axonal or dendritic process, they are called as dystrophic neurites. Okay, they often surround a central amyloid core which is surrounded by a clear halo. So let me show you. If this is the amyloid core over here, the dystrophic neurites will be surrounding like this. This is the picture that you are going to see, okay, when we see in histopathology image or H&E image. Now, dystrophic neurites, they contain tau aggregates that are biochemically similar to neurofibrillary tangles, okay. Now, what is very important that although neuritic plaques are mainly made out of A beta peptide, so in the center, that amyloid that you see, this is made up of A beta. But the dystrophic neurites that you see in the periphery, they contain tau, okay. So, you remember this point very importantly. Neuritic plaques, if you see, they are ranging between 20 to 200 nanometer, okay, and in the periphery of the lesion you can see reactive astrocytes and microglial cells can be appreciated in the periphery of the lesion. Now, plaques are present where? In the hippocampus, amygdala, neocortex with sparing of the primary motor and sensory cortex. Now, the amyloid core, if you see, basically they can be stained by Congo red or beta amyloid immunostain, and once we are staining with them with the help of beta amyloid immunostain, the dominant component is formed by A beta peptide, as I already told you, and very importantly both type of peptide A beta 40 and A beta 42, they are constituting the components of the A beta peptide. Now, this is your classical neuritic plaques. Now, one very important thing that we have to understand, very early on in the process, you have something which is called as diffuse plaque. Now, diffuse plaque is defined as that plaque wherein the A beta peptide deposition occurs without the surrounding dystrophic neurite. That is called as a diffuse plaque. Now, it's very important thing, it is basically present in the superficial portions of the cerebral cortex, in the cerebellar cortex and in the basal ganglia. They are found in very early stages of the plaque development, and most importantly they contain predominantly A beta 42, or A beta 42 is most importantly present in the diffuse plaques. This is the microscopic feature of neuritic plaque, as we can appreciate, okay, on the left hand side, the first image, as you can see that in the center there is basically amyloid, and surrounding that there is the dystrophic neurites which is present, as we can appreciate. So, this is the amyloid that we can see. At the center is the amyloid, and surrounding structures, as we can see, this surrounding structures, as we can appreciate, these are your dystrophic neurites that is present. Another structure showing the amyloid, and surrounding there is the dystrophic neurites that is present. Okay, this is the classical picture of neuritic plaque that is seen in H&E image. On the right hand side, we are seeing a very important immunostain wherein we are staining with a classical immunostain for A beta peptide, and this is a classical plaque, as we can appreciate over here. The core, this is the plaque core, as we can appreciate, and the core plaque, as we can see over here. Yes, this is the core plaque, okay, as we can appreciate. The plaque core is immunoreactive for A beta protein, as we can appreciate in this diagram. Now, this is a very important stain that is called as the Belchovsky silver stain. Okay, it is showing the classical senile or neurotic plaque over here. So, if you look at this particular diagram over here, okay, this is the silver stain which is very clearly showing this process. So, what I want to show you over here, if you see at the center, this part, as you can appreciate, this is the central part containing the A beta peptide, okay, and on the outside periphery, the presence of dystrophic neurites is there. Okay, dystrophic neurites are there. Okay, so this is very commonly seen in case of Alzheimer's disease. This is the Belchovsky silver stain which is demonstrating the senile or neuritic plaque. Now, the second very important pathological hallmark of Alzheimer's disease, as we can appreciate, is the presence of neurofibrillary tangle, okay, which is composed of hyperphosphorylated tau protein. Now, tau containing, now these are, what are the tangles? They are nothing but tau containing bundles of paired filaments present in the cytoplasm of the neurons that is going to displace or encircle the nucleus. Now, what happens in the pyramidal neurons of the hippocampus? Okay, the neurons, they form some shape like this. Okay, so what happens that the nucleus is basically pushed to one side, whereas the material is basically present in the cytoplasm like this. So, they look like flame shaped tangles. Okay, so that is why they are called as flame shaped tangles, especially in the pyramidal neurons of the hippocampus. At places where the cells are rounder, okay, where the cells are rounder, so these tangles will be seen in a more rounder configuration. They give a basket weave appearance of the fibers around the nucleus. So in this case, we call it as globose tangles. We call it as globose tangles. Initially, the neurofibrillary tangle, they are intracellular, but with disease progression, the neurons are damaged and they die, and the neurofibrillary tangle is going to come out. That is, they become extracellular. Okay, and such fibrils, if you see, you will see such depositions of such neurofibrillary tangles which is outside the cell, which is present extracellularly. They also called as ghost or tombstone tangles. We also call as ghost or tombstone tangle. Now the diagnosis can be made on histopathology, immunohistochemistry, and for clear-cut diagnosis, for more clear visualization of the tangles, we are using the same silver stain, that is Bell-Chavsky stain. Okay, in the HP we can see basophilic fibrillary structure that I will show you with the help of diagram. Now remember, in contrast to the plaques, in contrast to the neuritic and diffuse plaque, tangles seen in other neurodegenerative disease as well. So therefore, they are quite non-specific for Alzheimer's disease. So remember, the neuritic and diffuse plaque, they are mainly seen in Alzheimer's disease only, whereas the neurofibrillary tangles can be seen in other neurodegenerative disease as well. So they are less specific, or they are non-specific for Alzheimer's disease. Okay. So tau, if you see, they are present, the tau protein, they are an important component of neurofibrillary tangle, and they are also forming an important component of the dystrophic neurites which are surrounding the neuritic plaque that we have already seen before. Okay. Coming to the microscopic appearance of the neurofibrillary tangles, if you see, so if you appreciate over here, these are the pyramidal neurons, okay, pyramidal neurons of the hippocampus, and if you see the deposition in this silver stain of neurofibrillary tangles are looking like a flame. Okay, so this is the Bell-Chavsky silver stain which is showing clearly the black and the dark flame like neurofibrillary tangles. Okay, neurofibrillary tangles. So let us appreciate.